It's going to be lightning session, jam-packed, action-packed. We will have no time to cover everything. The intention of this day is not to solve all the problems with AI and medical education, if you've kind of figured that out. We're going to give you a preview of some of it, seeing the material you can use and reuse. But the point is to follow up, and we'll have a whole hour reception at the end of the session where we encourage you to go right up to the speakers and panelists to discuss further. So without further ado, let's start diving in with our first lightning demo from Dr. Preiksaitis. Would you like to take it away from our emergency medicine, talking about many different educational applications? Please, take it away.
Thank you. Thank you for having me. My name's Dr. Preiksaitis. I'm an emergency physician and a medical educator in the Department of Emergency Medicine. I also co-direct the Human Experience and Advancement Lab. And our focus is really on using AI and informatics tools to better understand how humans perform within clinical environments and how they develop. Let's start with this. I think this is what we think of most of the time when we think of medical education, like a nice controlled classroom environment. When we talk about deploying AI here, we think about AI chatbots teaching students in sort of this very quiet, controlled environment. But this is more my environment. Not really, our ED, you can go see it. It's much nicer than this, but it's chaotic, it's crazy. The medical students are not as stressed as this. But a lot of medical learning that happens is beyond those first 2 preclinical years. It happens in the clinical environment. It happens when you're interfacing within a complex system. And it's really hard to gather information about training during that time and also to provide useful feedback to residents or students that are learning. You know, I'm sure we'll hear about board prep, and a lot of the information that's been published regarding AI in medical education has been focused on AI's performance on medical licensing examinations. So you might have seen ChatGPT pass the boards and all this discussion about how much medical knowledge AI has. But really, if you look at, I have Miller's pyramid here because I'm a medical educator, and every education talk needs a triangle or a pyramid of some sort. But you know, medical knowledge is really the base of that. Knows how is really the beginning, and it's really in the shows and does. Those are the performative aspects that AI doesn't even really get to. And this is sort of what I tend to focus on in terms of my use cases for AI and training in the clinical environment. So the thing I'll ask you as educators, and something that I think about all the time, is what is something different I can do? What can I do with AI that I could never do before? And it's not necessarily making question banks faster or creating a lecture in less time. It's something that is new and different in education that we've never been able to do before. And this is what we spend time in the lab talking about. And sort of the main themes that I came up with today were using AI to illuminate, using AI to map, and then using AI to measure. So the first one is AI to illuminate. Now this chart, you don't need to see all the details, but this shows something we were never able to see before. This is describing attending physicians' influence on residents' CT ordering patterns. So what we did is we developed an AI model to predict the likelihood that someone would have a CT scan in the department, and then looked at interaction terms between residents and attending physicians. And you can see there are some attending physicians that are strong influencers or strong reducers that either shape to order more CT scans or less CT scans. And that's not necessarily saying it's a good thing or a bad thing. It's understanding that there's nuance in how people are learning and how people are interacting with the physicians they work with in the space. This is another graph that we did looking at, again, using this predictive model, looking at how individual physicians vary in terms of what would be predicted for their imaging utilization. So you can see that there are some people, this gray line is sort of within the bounds of what would be expected by normal variation. And there are a lot of people that lie way outside of those bounds. So there are people that are ordering much more imaging or much less imaging that you would be expected based on using a predictive model. And again, from an educational standpoint, this isn't necessarily to say you need to do a better job ordering less CT scans or more CT scans. It's to understand a little bit more behind the why. Why is this person ordering a lot more scans? Are there medical knowledge gaps in terms of clinical guidelines or how they could perform better in the environment to better effectively use resources? And before we were able to do some of these analyses with AI, we weren't really able to delve into the specifics of individual physician performance. A lot of people just got a number and said, you ordered too many CT scans this month, order less the next month. But really, we're able to drill down and look at the clinical cases and then design educational interventions focused on people's practice variation. The next area is AI to map. So again, a small chart, but what these charts show is another thing that we haven't really been able to see before. Each line represents an individual resident's learning trajectory over a 4-year training program. And what this is it shows the cumulative incidence of new clinical cases, topics that they haven't been exposed to before in the clinical environment. And this was done using an AI NLP pipeline. There's been a little bit of work that's done using ICD-10 codes or chief complaints, but what we actually did is went into every single note and used this pipeline to extract what were the key elements of a patient's presentation, what were these people discussing in their medical decision-making, what were they considering, and what had they actually been exposed to. And you see there is a lot of variation. Some people hit the ground running, some people have plateaus early, some people plateau later. Again, it's illuminating some of the nuance in terms of training that a lot of times we think you're in 4 years of residency training, by the end you're a competent physician, and that's the end of it. But we're seeing we can look at a lot more of this variation, and then we can design targeted interventions to say, maybe this person needs to spend more time on a different rotation, or maybe they need some additional didactic experiences in order to fulfill those gaps in their knowledge that are potentially making them a little bit lower on the curve. We use this actually to do an analysis related to policy decisions. So right now in emergency medicine, there's a discussion ongoing between 3 versus 4-year training models. And we looked at some of the data using these learning curves from 3 versus 4-year training programs. And we're actually able to see that in the 4-year training program, our residents achieved much higher number of clinical topics that they were exposed to. Okay, the last point I want to talk about is AI to measure. So this is using EHR data and looking at actually interactions with the EHR. And what you see here is progression in documentation efficiency. There's no assessment right now in medical education really focused on documentation efficiency, but it's a huge part of our practice. We spend a lot of time interacting with the EHR, whether that's a good thing or a bad thing we can talk about. But we see that people are progressing as expected from first year to later on in training. And you can break this down into individual residents. You can give them some information about how they could be doing better. And it's not just about typing faster, it's about synthesizing knowledge and communicating more effectively over the period of time in training. So that's just a lightning overview of some of the things that I'm thinking about, but I really think AI can unlock a lot of opportunities to go beyond just thinking about medical knowledge and thinking about how do we understand what people are doing in this complex environment where there's a lot of things going on, how do we provide them some actionable information and deliver targeted educational interventions that are useful to them. Again, thinking about this question, what can we do now that we couldn't do before? What are some hidden curricula that you can pull out? What are some targeted interventions that you could develop as an educator that you haven't been able to do before? All right, thank you very much.
Fantastic. Or you're live up. Fantastic. Next, we have a student doctor, Mitra and Alikhani. So I think this will be very good practical. Here's an actual medical student, and this is what she actually does. Whether you thought they were going to do it or not, please take it away.
Okay. Hi, everybody. My name is Mitra Alikhani. I am a first-year medical student here at Stanford, and today I'm going to be talking to you about how I use AI in my medical education to learn more faster. So a little bit of background about me. I was an ICU nurse before I came to medical school, and the reason I think that's important to tell you is because I am not a computer programmer. I have never trained a large language model, and the tools that I'm suggesting today are things that anybody can use to maximize their learning. Unfortunately, I have no conflicts of interest, which is sad for me, but good for you, because it means that everything that I recommend today are actual things that I think would be practically helpful in your everyday life. And don't feel the need to write anything down frantically, because at the end, I'll have a QR code that has a cheat sheet, so you can scan that, and it'll give you all of the information that I'm talking about in my slides today. So a quick agenda. We're going to talk about taking a source and then turning it into an outline, and then using that to make flashcards or practice questions. And then I'll also talk about interactive modalities, such as podcasts or a standardized patient interaction with AI. Some of the resources that I'll be talking about today include Notebook LM, which is Google's AI platform, This is a really useful tool if you're trying to stay really close to source material. You don't want anything pulled from the internet, for example. I'll also be talking about ChatGPT, which is OpenAI's platform. This one tends to be a little bit more creative. It can pull from the internet. It can make mistakes. And then finally, I'll be talking about Anki, which is a really popular flashcard management app used by medical students. So the biggest question that I have been wanting to try to answer is how do we integrate and learn massive amounts of information quickly? And I'm sure that if you are a medical student or a doctor or a resident or a fellow, you have received a slide deck with 100 slides. I'm sorry if this makes you nauseous. It makes me nauseous too. And you've been wondering, how am I going to learn this as fast as I possibly can? And this is just one example from my neurobiology class that I'll be going through today, but I want you to know that this strategy, the strategies that I'm talking about today, can be used with step 1, step 2, boards, continuing medical education, whatever it is. And so let's say that I received this 100 slide deck and I want to make an outline before I go to class. So maybe I'll go to Notebook LM and I'll upload my sources and I'll ask Notebook LM to make an outline for me. And this could just be a useful tool that I can review before I even get to class, so I have a priming of the material, I know what to expect. And then now I also have a structure for my notes. I can add things to it as I'm sitting in lecture, I can add photos, I can add diagrams, and it's a pretty simple way to get a basic structure of what to expect for my day. But I could also use this same tool to generate a podcast. Dr. Chen mentioned this earlier. It's a pretty fun tool. It's quite interactive and realistic. I would highly recommend playing with it yourself if you have not yet. I think it's quite helpful, and it's a great way to passively absorb material as you're doing chores or on your commute. So we'll do a quick listening of this podcast.
Welcome to the deep dive. Today we're really getting into the spinal cord. It's that, vital superhighway for our nervous system.
Yeah, exactly. We've got some great materials here, lecture slides covering the anatomy, blood supply, even some clinical applications.
Right. And our goal really is to cut through the complexity.
So that's just a quick example of what I might listen to on my bike ride to class. So let's say now I've gone to class, I have my outline, I've added photos, I've added details, and now I want to make it into flashcards so that I can actually learn the material. So I might copy and paste this into ChatGPT with a few simple prompts and ask it to use this format to make a set of flashcards. And it can literally make a 2x2 table with questions on one side and answers on the other that are my flashcards. And I can immediately upload them into Anki, into Quizlet, or I can just study directly from the table. And it really takes out those hours of labor that used to go into getting to the study process. Before, I'm sure many of you in this room who are doctors remember spending hours writing an outline by hand or making flashcards by hand. And I'm very excited to say that I can actually skip all of those pieces and just go straight to the learning aspect, and it can really maximize your learning. So that's one way that I can use it. I can also use it to make practice questions. I can simply go into ChatGPT, take the same outline with a separate prompt, just asking it, please make me practice questions based off of this outline. And it will automatically generate a set of practice questions. I can ask it for thorough answers and explanations, and it will do so. And obviously, with ChatGPT, you have to use your judicious judgment about what is actually true and be skeptical of everything that you read. But it is a really helpful tool for me to review the information in that way. And it can also be useful in figuring out where the gaps in my knowledge are, while also solidifying the things that I feel confident in. And then finally, I'll use it sometimes to even just talk through concepts one question at a time. So I might tell ChatGPT, hey, I'm really struggling with this specific topic. Can we talk about it? And so it will give me one question at a time, and I'll tell ChatGPT what I think the answer is, and it will tell me whether I'm right or wrong, and why, and where maybe I can focus my studying on more. And part of the reason that I've done this in this order with Notebook LM first and then ChatGPT is because I know that Notebook LM is not going to hallucinate and pull from the internet in the same way. So it gives me a little bit more confidence in feeling like, okay, if I put it through Notebook LM first, I can feel pretty good about the fact that the information that I have in that outline is pretty accurate. And then once I go into ChatGPT, I can cross-reference there and figure out if I'm correct. And then finally, I'm going to talk about using ChatGPT as a standardized patient. And this is a pretty fun tool. I have been using it this week because I have a standardized patient exam coming up tomorrow. And I think that it has some major implications. What I'm going to say before we start the video is that I did not give ChatGPT any other prompts other than what you see in this video. So this is the start of my interaction with ChatGPT. I did not give it any input before this conversation, and ChatGPT has made up the entire clinical scenario itself. And then we're going to start the video, please.
Hi, my name is Mitra. I'm a first-year medical student, and I have a standardized patient exam this week. Could you practice my history and physical and be a patient for me, and then give me feedback at the end on how I'm doing?
Of course, Mitra. I'd be happy to help you practice. Let's get started. Whenever you're ready, you can begin by asking me about my chief complaint. Feel free to take your time.
Thanks. Could you tell me a little bit about what brought you into the clinic today?
Sure, I've been feeling this persistent headache for the past few days. It started out mild, but now it's pretty severe. I've also been feeling nauseous and sometimes lightheaded.
Have you found anything makes it better or worse?
Well, resting in a quiet room seems to help a little, but the headache doesn't go away entirely. It seems to get worse when I'm exposed to bright lights or loud noises.
Thank you. So just for what I think that this is useful for, at the end of this video, I actually asked ChatGPT to give me feedback on my performance in the interview, and it had great suggestions for additional questions I could ask, what I should do in my physical exam to elucidate relevant findings, and what other review of systems would have been important in my questions. And I think this is also a really useful tool. Let's say if I'm going to a new rotation and I'm unfamiliar with common chief complaints. I could tell ChatGPT, hey, I'm starting my orthopedics rotation tomorrow. Tell me, pretend to be 5 different patients for me so that I can get a sense of what to expect. And then after that, those interactions, I can also tell ChatGPT, now can you pretend to be my attending? Ask me questions. What am I most likely to be quizzed on during rounds? And so it not only allows me to improve on my history and clinical taking, like history and physical taking, it also allows me to improve on my clinical reasoning. And so I think the implications of this are pretty amazing. So that concludes my presentation. I really appreciate your attention today. And here is the QR code to the AI Tools cheat sheet. And please come find me later if you do have any questions. Thank you so much.
Thank you, student Dr. Alikhani. That was amazing. Quick question before you leave. Who taught you how to do all this stuff?
I figured it out myself with the internet. So anything in theory other than medicine can be learned from the internet.
Fantastic. Thank you so again for the student Dr. Alikhani. We're going to, absolutely. If we can bring on Dr. Andrew Berg and Dr. Ben Muller from Sketchy. Apparently, they're one of the #1 just learning tools that all the medical students use. They talk about Staph aureus, and there's a king and a golden. I'm like, what are you talking about? And apparently, it's all the students use this, but also thinking more about developing tools. And we want to see what are other commercial applications that are emerging that our students can and will use. Do you have the clicker?
Yeah. If you've been to medical school in the last 10 years, you're about to hear the voice that haunts your dreams.
Great.
Please, take it away.
Except much slower, not 2 times speed, like I'm sure you guys might be used to. Okay, so, I'm Andrew Berg. I'm the co-founder of Sketchy and also a practicing emergency medicine doc at Kaiser here in Northern California.
And I'm Ben Muller. I'm the chief content officer at Sketchy and a reformed urology resident.
And we're excited today to be talking not about Sketchy, but about DDX, which is an AI case-based learning platform that we've been developing. For those of you who aren't aware of Sketchy, we're known for creating story-based visual mnemonics that help students really just cram all of the information they need to know. But we wanted to take that step further and help them apply that information in the clinical setting. And so that's why DDX was born. Go ahead. So we recruited a network of faculty across the country who are across multiple specialties, who are not just excellent clinicians, but also people who have dedicated their lives to medical education. And they've helped us create cases that we think reflect the ambiguity and complexity of real-life clinical scenarios. We, this past year, have somewhat stealthily been running pilots at medical schools across the country. We've done over 20 pilots. And what faculty are finding are that students are demonstrating improved diagnostic reasoning and are reporting higher confidence in their history taking. And students, we're seeing just like the experience, like the low stakes environment. And so that's all been really exciting for us. And just these past few weeks, we've begun rolling it out to students at the Sketchy user base. And so we're slowly expanding reach to hopefully the majority of med students in the country. And as we get more data, seeing those simulated conversations, hopefully hundreds of thousands or maybe millions of clinical conversations will continuously improve and create a even more engaging experience. So Dr. Thomas didn't want lectures, so we'll go ahead and get to the demos. Yeah, so without further ado, Ben.
So this is the case of Michael Jones. He's a 52-year-old guy coming into the ED. For this case, we're working with Dr. Reed, and I'll let her introduce herself.
Hi, I'm Dr. Reed, the attending in the ED today. A new patient just came in with chest pain, Michael Jones. Can you go interview Mr. Jones and see if you can start assembling your differential for what might be causing his chest pain?
Thank you, Dr. Reed. So we move into a conversation with a patient, and the sort of structure here is just like you would structure a conversation with a standardized patient, with the model, much as in Mitra's example, sort of playing the role of the patient. And so we've given it the patient's history, its background, its full story, as well as some rules of engagement for how to respond if the student tries to ask too many questions at once or go off the rails or whatever it might be. And so the student has this sort of naturalistic conversation with sort of real life responses back. And when the student asks a good question and elicits a pertinent positive or negative, we award them what's called a key finding. Med students love gold stars, so we give them a gold star. These key findings are a way to let them know that they're on the right track, that they're asking good questions. We're sort of scaffolding this learning experience for them. And we found that it makes it really engaging for them. They like getting these key findings. They like to continue engaging with the conversation. And so they sort of move through this sort of clinical reasoning experience in a meaningful way. For this particular conversation, you can see we have 7 of those key findings. That varies a lot depending on the conversation, as you'll see sort of as we go, the condition, the acuity of the case, and so on. We have a message limit here for these students. That 40 messages, we think, gives med students the option to ask all the questions they like to ask about pets' names and all the things med students do, but also reminds them that there are some real-life constraints on their time with patients.
And we've taken an agentic approach to this in that the patient doesn't know their diagnosis, doesn't know the key findings, so hopefully students can't cheat.
That's right. So quickly, you just saw our talk feature. You can go back and forth with voice with the patient, although that doesn't work super well in this demo. And then we have a hint feature. So we noticed as students particularly got sort of to the end of the list of key findings, they're having trouble with that last one or two. They can ask for a hint. This is toggleable. And what we found is that hint leads them to get the key finding on their next message about 50% of the time. So we feel like we're right in that sweet spot of we're showing them the door, but we're not necessarily like shoving them through it. So for the purposes of this demo, we won't go through all 7 of the key findings, sort of the whole rest of this conversation here, and we'll move on to the physical exam. We do the physical in a couple of different ways. Here we'll have a conversation with the attending. We provide some context first and remind you of the patient's vitals before we get into that exam. And then in this conversation, we can ask the attending for exam maneuvers, and then she'll give us the results of those maneuvers. Now, as always in this platform, we want students to think critically. And so if they say something super general, like, tell me the cardiac exam, we ask them to be a little more specific and thoughtful about what they're looking for on that exam. And so here we might say, okay, what are the heart sounds? And she'll tell us, I hear regular rate and rhythm, no murmurs. And that maybe gives us a clue about what might or might not, in this case perhaps, be causing his chest pain. And so we'll move on from here to the differential diagnosis conversation with the attending. We called the platform DDX. We think this is a pretty important part of this experience. First and foremost, because this is where the student kind of gets to demonstrate that they've been thinking clinically, that they've been applying some clinical reasoning to what's been going on so far. So hopefully, in the interview and on the exam, they've been asking questions in a hypothesis-directed manner. They have a sort of a differential list in their head or on paper or wherever that they're dynamically updating. They're adding conditions to it. They're removing conditions from it, sort of moving things around on the list. And so we asked them for their top 3 conditions on their differential, but we don't just want the list. We want them to, again, sort of think a little deeper and go back to the interview, go back to the exam, and think about why that condition is on their list. What did you learn from the patient that leads you to include this condition on the list? So I think one really powerful thing about having a large language model underlying this conversation is that while the scope of sort of correct answers is relatively predictable and you can kind of account for that in advance, the list of crazy things a med student might say is vast and perhaps unending. And so the large language model, with the context of our case, allows us to respond appropriately when the med student says something wildly off base, to coach them and sort of bring them back to reality and help them understand why that answer perhaps is a little bit or a lot wrong. Again, the differential we think is a super important part of the conversation. We'll move on from here. Depending on our cases, the sort of next step can vary widely. Here, we'll have Dr. Reed place some orders. Now, this could be a series of multiple choice questions about what workup the student would want. This could be a way for the student to sort of input what orders they want. Here, because we want to focus on some later steps in EKG interpretation and patient management, Dr. Reed just tells us what she's going to do, also a classic attending move. And so you can see the list of her orders there. And so we'll move on from this list of orders into getting to read an EKG, which I will make one of you, I won't actually do that. Did it freeze? Oh, there we go. Okay, cool. So again, I won't make you read this. We're going to go kind of quickly through it. But if you scan this EKG quickly, you can see that it's a nice, friendly EKG, sort of nothing concerning here. We ask the student to interpret this for us. And again, we don't want them just to say, looks good, right? They can't just say normal. They have to go through and read this EKG systematically the way they're taught to. So what is the rate? What is the rhythm? Do you see any segmental changes? We want to reinforce this behavior that they're taught and, at least for me, reflexively reject. They just want to say the final answer, but we want them to go through it systematically here. We now introduce a light sim element, so the patient changes a bit. He starts having some chest pain. You get paged by the nurse to go back and see him. It's coincidence that this EKG is blue and the last one was pink, but especially for the EM docs, this looks bad. Here, because of the acuity and because of the focus of this conversation is really on management, we let the student just say, I see a STEMI. And once they've made that diagnosis, we really push them to think about management. And this is something that, especially for earlier learners, they don't necessarily get to do a lot, to sort of manage a patient. And so, great, you've diagnosed a STEMI. You're the doctor. What are you going to do about it? One thing we also like to emphasize here is some of the stuff that, again, especially earlier learners don't necessarily think about. Patients typically don't walk into the hospital with a line. They don't walk in on the monitor, right? And so putting in some of those orders is an important part of their patient care. I'm a simple urine doctor. All I know is get cardiology on board, but you could go through the rest of this case and order heparin and aspirin and all the stuff you're supposed to do. So I won't make you go through all these questions yourself. We'll sort of whiz through them, but we have the opportunity to add questions, whether at the end or sort of sprinkled throughout. And as I sort of alluded to before, they're a way to modulate the difficulty. For earlier learners, fact recognition is often easier than fact sort of generation or recall.
And we're running out of time, so we'll wrap up here. But I think case-based learning is already prime time. It's great right now. This low-stakes practice is here. And I think as AI and LLMs are brought increasingly to the bedside, we're going to see that this is only going to get better, that LLMs will act even more like realistic patients. And so I think that this low-stakes practice will become increasingly present in medical education, and we're just fortunate to be able to contribute in some way and excited to see where this goes. So thank you.
Thank you.
Thank you, Dr. Berg. Thank you, Dr. Muller. Excellent. We'll just keep things moving along with Dr. Sharon Chen. I'm going to talk about AI clinical coaching and see the range of possibilities, simulations, but also maybe we're even thinking about how we think and learn to reason. Please, Dr.
Super.
Chen.
Thank you. Good afternoon. Thanks for the organizers for this opportunity. And we're just really excited about telling you all about AI Clinical Coach. We built this particular AI education tool to foster thinking habits in clinical medicine through AI augmented learning. And we built this tool to be used specifically in the hospital and clinics. All right, so building the tool like this takes multiple disciplines, and I really wanted to start out first with the team. I am a clinical professor in pediatrics. I'm an active clinician in pediatric infectious diseases. Kathleen Gutierrez was my teacher and one of the very best thinkers ever. Shima Salehi is my long-term collaborator and co-PI. She is an assistant professor in the Graduate School of Education. I also have this really great opportunity to collaborate with highly skilled educational technologists and TDS engineers, William Bottini, Tila Vessa, Peter Wynn, among others. All right. And so what I'd like to do first is frame this talk with a question that I'm going to give to you, and I just want you to answer in your head. You don't have to, there's no polling here. All right. So here's the setup. Think of a small problem that you have had at home. And what question did you think about first when you were solving that problem? Maybe your toilet didn't flush. Maybe you were really jazzed about making cookies, but there are no eggs in the refrigerator. Maybe you went to the bedroom, you flipped that light switch on, and the lights didn't come on. What was that first question that you asked yourself as you were trying to solve the problem? I'll give you 15 seconds. All right, keep that question in mind for later. All right. You all know we are in this rapid evolution of generative AI, and it's made me think a lot and reflect a lot, and this is my conclusion. We are still living right now in a knowledge mindset. What we need is to start cultivating a thinking mindset in order to critically and thoughtfully apply that information and knowledge that is generated by generative AI, right? And in order to do this, we need something new. This is why we have built AI Clinical Coach, in order to cultivate this particular thinking mindset. Now, our team is a learning first team. So I want to talk to you about the learning origins before I tell you about the technology. AI Clinical Coach is based on a problem-solving framework from the learning sciences. In this figure that you see is from a study from Carl Weinman's lab at the Graduate School of Education. All right. And so what they did was to look at how experts from disparate fields in STEM, how do they solve problems? And remarkably, they all use very similar practices, those that you see in the orange boxes. And my guess is that these practices that you see here are familiar to you as you think about solving a patient case problem. And we have done that translation to go from STEM to clinical medicine. Two other very important points about this figure. One, reflect, that word. It means about self-evaluation to make informed and intentional decisions. You can see that that's connected to every single practice in problem solving. Two, knowledge encompasses all problem solving, but it is not a practice, right? So now I told you that reflect connects to every single problem solving practice, but does it make a difference in learning? And it does. So this is a figure from one of Shima's, Salehi's studies, and what she did was to look at engineering students, and engineering students who were explicitly taught and learned to use reflection practices as they did their problem-solving activities outperformed students who did not. Now, I would like all of our physicians and healthcare providers and trainees and students to be like that, those engineering students in that green group. Because if we can make reflection practices, thinking habits, a habit, then that can lead to better patient care decisions. We can produce experts to solve any new future patient cases, and the end result, more effective patient care. All right? Now, the problem, though, is why don't we teach and train this better? And there are many barriers. There's a default to the knowledge mindset. There's no common language or shared mental model. There's no guidance on how to teach this. There's inconsistent assessment and lack of longitudinal evaluation. And we can mitigate against those with our problem-solving framework we call the Thinking Habits Matrix. The AI adaptation of the Thinking Habits Matrix can mitigate against clinician time constraints that is ever present, right? And the AI can help the teacher by relieving the cognitive load and help the teacher by longitudinal tracking with real-time analysis, retention, practice assistance. Right? So essentially, AI Clinical Coach can break down all of those barriers that I just showed you. And the AI adaptation makes it easier to use in the hospital and clinics where it is busy. This is the problem-solving framework we call the Thinking Habits Matrix. It consists of 6 elements that encompass problem solving. We intentionally call it the Thinking Habits Matrix because we want this thinking to be a habit. In each of the thinking habits, we have self-reflective questions. If you look at some of these questions, it may be similar to the one that you pose when you're solving your small problem at home. So for example, is this the most important problem to solve? Like, do you really, really need those cookies, right? So in this particular figure, just be mindful that thinking habits is not the same thing as clinical reasoning. All right, there's an overlap. And so there's familiar clinical reasoning words at the bottom of those boxes. I told you that the Thinking Habits Matrix is adapted and enhanced by AI. And AI listens to the case presentations through a simple web-based application. Everything is secured in REDCap. It provides reflective questions using the Thinking Habits Matrix and fine-tuned prompts. It facilitates teacher and trainee conversations, providing you personalized coaching that you can use for your trainee, and it tracks thinking habits over time so that the teacher and the learner can grow together. Here are some snapshots of the user interface. And let me just go through a little bit of how this particular thing works. So the trainee shares a case presentation, the attending listens, and AI Click records it. There is a speech-to-text transcription, and then it goes into an AI large language model that analyzes it based on our prompts, based on the Thinking Habits Matrix, all right? In minutes, then the attending gets a Thinking Habits report, and it is scored very simply with red or green, yellow, red to give you a simple scoring system based on the thinking habits elements, all 6 of them. It also, the bot, will give you coaching questions that the teacher can choose to use or not. And this is personalized to the trainee. And over time, the trainee's thinking habits progress is tracked over multiple case presentations, all right? We are actually running a study right now and getting data, and we're very excited about that. I just want to be clear about some things of what AI Clinical Coach can and cannot do. It can focus on thinking habits for problem solving. It provides self-reflective questions to consider as you make patient care decisions. It centers on the provider or the teacher-learner pair. It augments the teacher. The teacher is still in charge. AI Clinical Coach does not provide solutions or knowledge or a patient diagnosis. It does not record the patient, and it does not replace teaching or coaching. All right, we're very excited about the data from our first cohort. We're trying to have a second study cohort in the latter part of the year. We welcome collaborations to understand where we can use AI Clinical Coach, and we're hoping to expand beyond clinical medicine to general problem solving. If you are interested in connecting with us, please use this QR code to get in touch. Thank you for your attention, and I appreciate all of the time.
Thank you so much, Dr. Chen. We're going to see more of the exciting things happening at Stanford in innovative ways and deep thinking involved. Go ahead, you can on stage. Next, we're going to have one of our key clinical informatics star fellows, Dr. Aydin Zahedivash, representing. He's actually the one who's driven a lot of the work collating that core curriculum that we pointed to earlier, but here he's going to be talking about some other tools that we can use in learning and practice. Take it away.
Awesome. Thank you, Jonathan. Hi, everybody. Thank you for having me. My name is Aydin. I'm one of the general pediatricians here at Stanford and one of the clinical informatics fellows as well. And I'm here to tell you about a pretty neat tool that we made to enhance resident education in our peds primary care clinic. So this slide was initially designed to co-introduce Vishnu and I as co-presenters, but he unfortunately got sick, so he can't be here. But he is an outstanding primary care doctor and software engineer who built a lot of the infrastructure behind what we're doing. And the slide is also here to emphasize that we are also tinkerers and engineers. We love building things. The two of us help with a series of our colleagues to help lead the Biodesign Digital Health Group, which is where we pulled together a lot of the prototyping and building resources for this. And one of the key tenets of biodesign is to carefully understand your problem before you look at the technology. So let's talk about the problem. As I said, I'm a general pediatrician, and I work as a preceptor in our resident clinic. And we interact with a lot of governmental and community resources to find things that our patients need. And there are a lot of really nuanced clinic policies and guidelines of how to recruit all these resources and find the right ones. And on top of that, it's a teaching clinic. So that means that we get the honor of working with medical students and residents all the time. But that also means that medical students and residents have a lot of other things to do besides being in our clinic. Residents rotate on average through the primary care clinic about like a half day a week or less. So figuring out how to navigate all these resources, which no one taught you in med school, is a hard thing to do at the beginning, and nevertheless, when you're there, like not very often. So what usually happens on the left, you have a resident with a question, and then do I search the complicated website to figure out where to get what I need, or do I ask the really experienced senior attending that's been here for many years? And the big arrow shows you that it's usually the latter, right? And that's a bottleneck, right? So I want to shout out one of our awesome pediatric residents, Dr. Prachi Kenny, who did some surveying of our residents to figure out where are the gaps and where are the problems. Finding the right forms, knowing how to make the right referrals, knowing what resources are even available. Like you know that you need something for a patient, but I'm not really sure where to get it or what the resource is. And if you look on the right, you can see that a majority of these trainees are searching at least 5 minutes per encounter for this information. That's outside of the patient chart. And if you see patients, you know that 5 minutes per encounter is a long time, especially when a lot of these visits are between like 15 and 30 minutes. So we did some prototyping and iteration through what solutions would look like, and we landed on what looks like a chatbot, which is why I'm here at the AI Day to tell you about it. So what we made is a custom retrieval agent. And for those who already know this, forgive me for saying what you already know, but in that green box is essentially a 50-page Google Doc of all the community resources and policies that we use in our community to take care of patients. And then all of that is chunked using a markdown mechanism. And then that is fed into a central database, which then joins it with a query and sends it to OpenAI and then feeds you a response. The model is tuned with a really low temperature. So that means that it won't tell you jokes and it's not gonna be very creative, but it gives you highly precise and really accurate responses based on what's in that green box. And if you know anything about making technology for providers or for users in general, technology is only half the part of it, right? So we were very intentional about how we made this. It is dead simple to use. There's no login. You just go to the website. There's only one user input, which is the chat box. And then there's some quick access links to what you need to know on top. Now this is live for the past like 1.5 months, and people are using it. So I thought it'd be fun to put you through what it's like to be a pediatric resident and see how it works. Joe, would you mind playing the slide? Thanks. So, nice, it works. So ADHD is a really common thing we see in pediatrics clinics. And how to screen for it is a process that requires a number of standardized forms. I just asked how to screen for ADHD. It gives you all the scoring forms for both the parent, for the teachers, and then you can print this out and take it to your visit and have them fill it out at the appointment. You did not ask for a cover letter for the teacher, but it knows that you're going to need one. So it gives you the cover letter so you can give it to the family so that they know what to ask for the teacher. And it just knows that you need that. And you think back to medical school and you think, oh, anxiety is comorbid with ADHD, right? Some kids can have both. Well, how do I screen for that in an 8-year-old? Well, there are specialized forms for that too. And it'll walk you through the forms and what you need to do in order to screen for anxiety in an 8-year-old. And you can, again, print these out, and then it gives you a scoring scale on the next sheet where you can score your patient's form. So sometimes residents will know that there's a process that we need to follow, but we don't know how to find it. So a lot of kids with ADHD might need an individualized education program with the school, and that requires coordinating between teachers, the school itself, and then parents. It's kind of a complicated process, and if you just ask for what it is, it'll give you didn't ask for the patient information forms, but this is something you give to the family to help them understand where they are in the process, and there's also other forms that you can use to request the plan from the school. You can also ask for a treatment recommendation, so over here it's going to think about like what do I mean by treatment options, and it'll give you a really useful guide of like the med doses, et cetera, for ADHD. And then what I find really cool after I zoom into this is that you didn't ask about cardiac screening recommendations for stimulants in kids, but it knows that you need to learn how to do that, right? So the last link on the response are the cardiac screening guidelines for ADHD meds that one of our cardiologists made, which is super helpful as a resident when you need to learn this stuff. And then so sometimes you know that like you need like a class of resources, but you don't really know where to find them. You can just type in the mental health resources. I need something for my patient who's screened positive for anxiety, and it'll output anything that's specific to our clinic, like the algorithm that's on top. And it gives you like when do you refer, where can you refer to, and then back in the response, it gives you the different resources that are available to you, which I think is pretty awesome. In our next slide, awesome. How do I do this? Uh-oh. Hey, Joe, can you go to the next slide for me? Oh, I broke. Can you try playing that one? I promise it's worth it. Well, yeah, here we go. Just a few more examples of relevant things that it knows how to do. There are a lot of really complicated processes in caring for kids in the community, including what is Early Start, which is the Californian version of early intervention for kids with developmental delays. And if you just ask about how to do it, it'll walk you through the complicated process and also give you educational materials that you can review on your own without the attending having to show you. Also, similarly, in our clinic, if you want to file an e-consult, there's a really convoluted process of like going to a different EHR, having to be in a specific context, and then having attendings do it. And if any one of those goes wrong, you're not going to get a response from your e-consult, and it knows exactly what to tell you. Other things that are really helpful that it does is if there's like any specific forms that you want, you can ask for example, like the sports physical form that I'll show you in a second, and then if you ask anything out of bounds, so like in a second, I'll have it ask for like who of Vishnu and Aydin is smarter, and it'll tell you, I have no idea, I can't answer that. It is too polite. I think we might be running out of time, so I'll go to the next slide. I think what's really cool about this is that it's like an example of the interdisciplinary environment we have at Stanford and what can come about. The idea came from Chetan Sarabu, one of our previous clinical informatics fellows and pediatricians at our clinic. Our medical director, Elizabeth Stewart, and I iterated through a lot of these ideas, Our by-design team helped build and prototype a lot of the design of it, and we deployed it within a couple months. On the right is a QR code that'll take you to our GitHub, where you can copy and implement this wherever you like. We intentionally made it open source so that other people could use it. Thanks again for having me, and thanks for listening.
Fantastic. Thank you so much, Aydin. Amazing work and so many implications. Like the real stuff you learn in medicine is not what's in the textbook. It's how do you actually get things to work in the community. And next we have Dr. Marcos Santiago-Rojas, leading a lot of really cool work with clinical mind AI. Please take it away. Is it clear?
Thank you so much. My name is Dr. Marcos Rojas. I'm a PhD candidate at the School of Education. I'm the director of Clinical Mind AI here at Stanford, but also I have with me today the two PIs of the project, Dr. Shima Salehi from the School of Education and Dr. Thomas Caruso from the School of Medicine. So let's think about something that everybody needs to learn in healthcare education, every health professional. When you think about that, you arrive to this conclusion. Clinical reasoning is this core skill that every health provider should learn when they go to university to study to become that health professional. In this mental process, you do many things. One of the core ones is collecting data from different resources to make decisions. And those decisions can be so different. And also, there are many, many ways to understand clinical reasoning, being this one just one of them. There are different models, different frameworks, different theories to understand what clinical reasoning is. Now, there is a challenge when we try to teach this to someone who just arrived to med school, which is how do I make this person competent in clinical reasoning? And the challenge when we talk to different universities across the globe was mainly two things. We usually teach our students with summaries of information collected by someone else. So this someone else collected all these pieces of information that you think will help your student learn. You put that together into a format. It could be this one, a multiple choice question, but also it could be slides, a handout, so many ways. And then this information, you ask some questions to the student or you walk them to this. The problem is that in real life, you never arrive to the doctor with this summary. Hello, I'm a 32-year-old man with, I've been coughing 2 days. You usually do everything from scratch. And the solution for this, we found it already in medical education, which is let's see real patients, or let's hire actors so they can act as patients. That is simulation, right? The problem here is that this very good solution that we created in the 80s, 70s in medical education is difficult to access and difficult to scale. Can you really take your student every day to the hospital to see as many patients as they need, or to the simulation center to repeat it many times until they learn? That is difficult to put together and scale. And also when you think about these two challenges, when you try to learn or improve clinical reasoning, this happens across the professional training of any health professional. So with that in mind, we started to think about an idea. What if we put together here at Stanford the clinical expertise of our med school, also with the learning sciences and all the knowledge and methods they have at the School of Education, and also all the technologies and the AI methods and technologies that they have at the Department of Computer Science to try to tackle these challenges when we try to teach clinical reasoning. And after months and months of discussion and also research, we arrived to this one idea that we call Clinical Mind AI. What is Clinical Mind AI? This is a learning platform powered by AI that is designed for one thing: to improve clinical reasoning, to allow you to assess or teach clinical reasoning. And also, we provide free access to any educational institution across the globe who wants to use this and do research with us. Now, in this platform, we do one thing with AI, which is allow you to create AI-simulated patients. That is the solution we found, so you can scale the simulations and repeat it as many times as you need. But also, we use the same technologies, AI in this case mainly, to do other two tasks. The other task is to provide feedback. So now we can take the data points from your students and provide feedback to them and insights to you about the student performance. But also, while talking with different companies and also with different universities, we learned that we need to do a third thing with the technology, which is adapt this platform to diverse medical curricula. Because when you teach your students, we usually assume that everybody else in the same discipline teaches the same way, and that's not true. And also, depending on where you are, you teach in a different way. So we decided to take the technology to that level and adapt the platform so you use it for your own purposes. What do we mean by that? We do three things to adapt the platform so anybody in the planet can use it. The first one, and the obvious one, is language. Most of the platforms are in English, but most of the learners do not speak English. If you go to all medical schools and you ask them in which language do you instruct your students, most of them are not in English. So we decided to take the AI and this technology to adapt the platform so patients speak that language, and also the platform and everything, even the buttons, are in that specific language for that institution. The other thing we decided to do is allow you to create the cases, because in most cases, platforms give you the clinical cases, which is great if I don't want to do anything and the cases are already there for me. But in most scenarios, you want to create your patients. You know what the students need to learn. So we allow you here to input the clinical case, whatever case you have in mind. And the third thing here is the understanding of healthcare and clinical reasoning. Depending on where you are in the world, you understand taking care of another human being in a different way. So for you, the metrics of success for your students are different. You want to measure different things. You pay attention to different things when your students go through a clinical case. So we can use the technology also, AI in this case, to ask you, what do you want to measure in these student interactions? And that's what we're going to give feedback about. Now, how it works? It works in the following way. We have an instructor, you in this case, who inputs a clinical case and metrics. Then we take that and we generate the simulation for the students. Then the students on the other side receive the simulation and they interact with the simulated patient. And finally, once they finish, we analyze the student performance based on the metrics you input at the beginning. And then now we give feedback to the students and the insights about the performance to you. But the question is, the first step, I'm going to input a clinical case. What is that? Think for a moment, what is a clinical case when you have created a clinical case for your students? What is a clinical case? And here is the important question to imagine. If I have a clinical case in a computer for a student and they click start, what should happen now? They talk to the patient, they answer a question, they watch a video, they learn about the content and they talk to the patient, or the other way around. How can we create a platform that is so flexible so you can create any sequence of events that you want using the technology? So that's why we created. Basically, in the platform, you will always have a simulation, which is a patient interaction. In this case, it's the medical history, and the instructor decided that you have to take the medical history. Because what if you want to turn that off? And the students just have to read it. But in this case, the instructor said, no, I want the student to call by phone the patient and take the whole medical history. But you can decide to, perhaps I want something to happen before this, or after, or in between. So in the platform, you have like these Lego blocks that you can put together and create any sequence of events so that when the students start and finish, they follow those steps throughout the platform and the clinical case you created. Now, this platform is designed to help you, so also we want you to save time. So the first thing we created was an AI assistant. If you already have the clinical case, and probably you already do, you can just upload the document, and we will take the information from there and create the simulation ready for you. Or perhaps you want to provide some information to the platform, and then we can generate the rest of the clinical case based on these small inputs that you gave at the beginning. Also, we have a library of resources because you are a physician who has so many things to do. So we need you to now create a clinical case. So perhaps you need some help from some colleague. So now also we created a library. So you can share the clinical cases inside the same university or go to the public library and copy from someone else who shared this across the globe so you can share these clinical cases and take from others in other universities. But also, we provide for you a full library of EKGs, X-rays, ultrasounds, etc. So you can also create simulations that are more complex with the resources that are already here. And finally, you can also customize the interaction because perhaps you want the students to, I don't know, they are residents. I already know they can take the medical history. Should I make them ask the patient all the questions if I already know they are competent? So perhaps you want to do this. Students just receive the medical history, they read it, and the complexity is about the questions. Or perhaps they have to take it, or even in medical test, instead of clicking the test, perhaps you want them to ask the test in an open-ended response. You can also here customize to what extent this is more difficult or less difficult. Finally, to finish, this started here at Stanford University, but quickly, and we started to work on this in August last year, but quickly, as Tom says, faster than the wind, this spread across the globe, and we started to provide access to several universities all across the globe in all continents. Today, we just started to onboard a new university in Poland. So this was a solution that we understood was needed in medical education everywhere. I want to thank our collaborators all across the university at Stanford. Without them, we wouldn't be here. And finally, I want to tell you that this is made possible by the help of so many like you. I see many professors here that are working with us. Thanks to you, your input, your feedback, and also the resources you provide, we're here today with a platform that can solve a problem, not only here at Stanford, but everywhere. And also, I've been learning while we're working on this that when we're all together, putting the best of us, we can do so many excellent things like this. And we can provide a solution that is not only here for us, but for everyone. And finally, I want to invite all of you to help us. There's so much to do, so much to discover, and keep on innovating in AI in medical education. So we need you. Well, thank you so much. And if you want to learn more, please visit our website, and we will be outside in a table to show you the platform. Thank you.